Yes, that has been simply outstanding. And I think at the outset, I'll just say that refractive surgery still seems to be the most successful and the most lovely surgery for a patient perspective, because they go home happy, at least 99% of them. And that's something that nobody talks about. And I just wanted to end with that session. Thank you so much, Bill, Marconi, Andres, and everybody over here for a great session. We're going to have the last session now, but before we do that, we have a technology question, and this one goes to Arthur Cumming. The question that I have is, what technology are you looking forward to the most in the post-COVID era, and why?
Visceral, the Visual Behavior Monitor, and the Lifestyle Match Index. This technology uses objective data to determine the patient's visual needs. Having the ability to match the patient's personal defocus curve that is obtained objectively by wearing this monitor on your spectacles for 36 hours to the defocus curves of all the available presbyopia correcting IOLs is extremely powerful. Firstly, patients are more aware than ever before after wearing the monitor of how much time they actually spend up close and on computer screens. They now request a presbyopia correcting IOL. The Lifestyle Match Index will soon also have the ability to compare different mix and match combinations, EDOF and X-Wave IOLs with different refractive offsets in the near eye and blended vision. We have never had this level of power before to help us select the best IOL design for a patient's visual needs. So biometry for IOL power and Visceral for IOL design. This is the future. Why? Patient satisfaction drives word-of-mouth referrals. We need to get the best data possible to select the best IOL for the patient, and the beauty with Visceral is this all happens remotely outside of the clinic, and it replaces long conversations based on subjectivity with accurate, objective data.
Well, that is wonderful. Before we move to the final session, let's also get a polling done before my challenging case panelists and moderators, as well as my speakers, can get on with their program. I get challenged in my OR less than 10% of the time, less than 25% of the time, 40%, or nothing challenges me. I'm Iron Man. Which one do you choose? Audience, get your clickers going. You have 10 seconds. And can we close this polling, please? Can we also have, all right, less than 10% of the time. So let's see how, can we close the polling results? All right, before we move on, we have a star-studded StarCast here for the final finale of this world webinar on cataract and refractive surgery. Can we have the final introduction for the final session?
Challenging Cases Session. The coordinators: Thomas Oetting and Ashvin Agarwal. Guest panelist: Partha, Biswas, India. Featuring speakers: Ahmed, Assaf, Egypt. Phaik Chee, Singapore. Nicole Fram, USA. And David Chang, USA. Organizers: Sergio Canabrava, Brazil, and Ashvin Agarwal, India.
All right.
Hey, my name is Tom Oetting. I'm sorry, my background, I had trouble with it, but here's a little flag. So that's part of the deal. I'm so impressed with this whole weekend. I just can't believe what Ash and Sergio put together. I mean, we recently had a little bit of success in the United States of launching a space mission. And I think next time we should have Ash and Sergio help, because getting together all these cats and herding them all together is an amazing, amazing thing. So we have the last session. Some would argue it's the best session. I hate to say that because it's been so good so far. The lack of my background, though, did point out an important thing. If you look back in my books, I want you to see here's a book from Dr. Chang. Here's another book from Dr. Chang. Here's another book from Dr. Chang. Here's another book from Dr. Chang. And that is the full extent of my introduction to Dr. Chang, who's going to present us an interesting case. Thank you.
Thank you, Tom. So we can run the video at any time. And this is a patient in their 50s with a posterior polar cataract. And I'll go ahead and start that. As you can see, it's so big, the red reflex is bad. So I'm going to use Zepto, which is a disposable automated handpiece that creates an automated capsulotomy. And it's going to give me, without this good red reflex, the need, it'll produce a perfectly circular 5.2 diameter capsulotomy. And I need that here because I need to be certain I have that, and I want a platform in case I need to put the lens in the sulcus. Now, and there you see the free floating flap. So one of the pearls, you can use any viscoelastic. This is Amvisc Plus, but I'm sort of going under the anterior capsule into the fornix so that I loosen the epinucleus before hydrodelineating here without the risk of a fluid wave popping the posterior capsule. And then the next pearl is by using horizontal chop. You can see it's soft. I deliberately avoid rotating the nucleus. So I have to tumble these little hemi-fragments into the anterior chamber. Because remember, when you rotate a nucleus, you're pushing against the posterior capsule and the capsular bag. And that will, in and of itself, sometimes rupture the posterior capsule. So this is the part where if you don't hydrodissect, it's a little hard pulling things out. So watch, I'm going to refill with viscoelastic before I retract the phaco tip. And then I'll go to the INA. And this is where I think that earlier step of visco dissection, it's a partial visco dissection. Remember, you only have to go under the anterior capsule and into the fornix to loosen things up. Now, I hope you can kind of watch the red reflex pretty carefully, because right around here, I start to see lens particles behind the posterior capsule. And so already knowing that there's this potential weakness in the posterior capsule, I'm now thinking I have to treat this as a case of posterior capsule rupture, even though I can't really see past my coaxial tip. So I'm thinking to myself, I cannot come out of the eye without first pressurizing the anterior chamber, because I absolutely don't want to have a rupture of the hyaloid face. And I just have to assume we have an opening in the posterior capsule. So it doesn't matter what viscoelastic you're using. Again, I happen to have Amvisc Plus here. So I'm on position 1, I start injecting, then I go to position 0 so I don't irrigate everything out and the viscoelastic can accumulate, and there is the opening. Now I'm going to look at it, and you see there's going to be a little white fibrotic tag, and I think that was the posterior plaque, and you can see that it popped. So the question is, this is a patient that needs a T5 toric lens, a lot of astigmatism, a young patient. And what am I going to do? I can easily put a 3-piece monofocal in the sulcus and capture the optic. But I think if I can convert this to a PCCC, I could possibly use the toric lens. So these are Barry Seibel's capsulorhexis forceps tips that you get from MST. And what I like about them is I can come in through a side port and rotate it so I can get the right angle of approach to grab, in this case, that little fibrotic tag. And you use some of the principles of Brian Little's capsule tear-out rescue maneuver to sort of gain control of this. Because remember, the posterior capsule is really thin. It's like a pediatric capsule. It's much thinner than the anterior capsule. And there I've rounded it off. So now the question is, if I've maintained the chamber and I don't have hyaloid face rupture, hopefully we can put in a toric lens. So I inflate again, it looks pretty good. You could, of course, try a single piece without the posterior CCC, but remember with a toric, we need to be able to rotate the lens into the right alignment, and that will extend any tear in the posterior capsule. Here is the Callisto to help me line it up. I'll put in a Myocol before I finally take out all of the viscoelastic. Of course, we're not going to go under the IOL in this case, but there you'll see the posterior capsulotomy. And remember that by not rotating the nucleus, If I had rotated the nucleus, I think that tear would have gone from coast to coast, would have been a very large defect that I wouldn't have had that option. Thank you very much.
Well, that's a wonderful case.
Fantastic. I think, David, that is just phenomenal. And we'll have some questions for you, but we'll keep that towards the end. We're going to now move on to Phaik Chee, who is probably the global rock star in showing us complex and challenging cases. So take it off, Soon. It's all yours.
Thanks, Ashvin and Sergio, for inviting me. So this is my patient who begged me, please save my lens, my financial disclosures with no relevance. She's a 71-year-old lady with bilateral trifocal lenses, persistent intraocular inflammation after surgery, especially the left eye. And you can see that the IOL is descended 3 months later with a decrease in vision for both distance as well as for near. And prominently, you can see this capsular phimosis. And she came and she said, please save my lens. And when I looked at the UBM images, I was horrified. You can see a buckling of the plate haptic here, and you can see the zonulisis. So this is the patient at the time of surgery. And this is the shrunken capsular opening because of fibrosis. And I knew I was going to encounter vitreous, which I elected to do from the anterior approach, from a clear corneal incision, although you can do this from a past planar approach, which perhaps would have been better. And you can see the buckled haptic here, the plate haptic here. And once I got rid of that vitreous, I was ready to start. Now, what am I going to do? Okay, so I decided that I had to save a capsular bag because there was no other good way to stabilize this IOL and to center it. So first of all, I'm supporting the entire capsular complex with 4 iris hooks. And then after I start to dissect to this area, the hook comes off, and I'm peeling the subcapsular fibrosis from the capsule. Now you have to be really very careful there because you can't see very clearly until you get the edge, and then you can see even the haptic buckling over there. So both sides, the haptics are being buckled inwards because of the severe capsular contracture, and I'm trying to relieve this phimotic subcapsular fibrosis in order to release the contracture on the capsular bag and on the lens. So it's really difficult, and I've shortened the surgery, and you can see this part, the haptic, the fibrosis is going under the IOL towards the posterior capsule. So I've decided, well, it's better not to go there because I've done dissection on the posterior capsule before for other cases, and I've ruptured that capsule. So I used the iris hooks to give me better exposure. I'm happy that the fibrosis ends here, and I'm just going to just amputate that fibrotic band there and see what I have. So when I examine, actually the rhexis has actually gone a little out here, but I'm glad because of the fibrosis coming in and the plate haptic, it does not rip. And I'm just thinking of how I can then reduce the risk for contracture and also support this lens and center it, right? So I can't put in the capsular tension ring because the rhexis is already not intact in just one area here, although it's not ripped up because the fibrosis prevents it from extending. And here we can use a capsular tension segment, which you can use even if you don't have an intact capsular rhexis. So I created a Hoffman pocket. You can see my ink mark there for 1.75 mm posterior to the limbus. And this is using a lasso created by Gore-Tex 7.0, right, through a 26 gauge needle. And that lasso, which I extend as a loop from this needle, is used to thread and bring that end of the suture loaded on the capsular tension segment through to the sclerofixation point here. And then I retrieve the sutures from the Hoffman pocket. And I'm going to do the same for the other side, being really careful. I decided that the intact side was the easy side. Now this is the difficult one. And you can see, in fact, the IOL is anterior to the iris here. And I've got my adequate support there from the capsular tension segment. And I'm just going to repeat the procedure to bring the suture borne by the capsular tension segment through to the sclerofixation site by use of this little loop of suture, which I call a suture snare, which has been published in the British Journal of Ophthalmology. And once I've gotten that through to the Hoffman pocket, I then retrieve the suture from the pocket. And now I've got this IOL supported adequately. I'm just going to adjust the tension here between the sutures with a 2-1-1 kind of knot. And after I satisfied with the centration of the IOL, I then fix the tension and finalize the knot and pop the knot into the pocket. It's important that the pocket's created deeply enough. And you can see this is a reasonable outcome. It was not perfect, but I thought it was reasonable. And 6 weeks later, you can see this IOL slightly superiorly positioned, but she had still persistent uveitis that subsequently needed immunosuppression. But this was the outcome, and I still had the corneal sutures there, which I can still remove. So she was very happy with me at this stage. So thank you very much.
Wow, that was incredible. Boy, every time I see one of your cases, I just can't believe what you can do. It really doesn't seem fair, and it makes me think I should refer all patients to Singapore. Going to know the truth. Well, our next speaker is Nicole Fram. Nicole has been a great mentor for me, and we've worked together on many projects. It may seem odd for an old guy like me to call her a mentor, but it's because of all the things that she's introduced to me. One of the coolest things that she's done is push the idea of using simulated eyes to practice complex surgery like we're talking about today. And so without further ado, Nicole, could you show us your case, please?
Thank you. Can you all see my screen?
Yes.
Perfect. So I just want to thank Ash and Sergio for doing this incredible webinar worldwide. I've learned so much, and let's get started with this cloudy complication. This is a patient, 76-year-old male, came in with intractable glare and these whiteout episodes. And on past ocular history, a cataract surgery 3 years prior with some toric lenses. And what you notice on exam is that there's 360 degrees of transillumination defects, and that this IOL is actually in the sulcus. And when you do gonioscopy, you can see that his whole angle is filled up with pigment. Unfortunately, he suffered glaucomatous loss and has a 0.9 cup to disc, although he is controlled at this time on one medication. And so here's another David Chang publication here, which in 2008 and 2009, we looked at all of these cases, and there is absolutely no indication for putting a single piece acrylic in the sulcus. So these lenses are not designed to be in the sulcus. So this paper kind of highlighted that we must have a backup lens that's ready for us in surgery in the event that we can't use the capsule. In 2010, John Berdal and Dr. Fass came up with this technique where you could do 4-point scleral fixation of a hydrophilic acrylic A060 made by Bausch & Lomb. And as Sergio pointed out earlier, this has wonderful stability. We get virtually no tilt. We were so excited. It was originally described with Proline, and then we later published on this with Gore-Tex suture. And so we were getting great results. So out of hundreds of patients at this point that we've done, we were really happy and felt great about it. I replaced the lens with an A060, and at post-op month 1, he was 20/25, 20/30, if you're a pessimist, and we were feeling great. And then this happened. So he developed a retinal tear. It was MAC on. He had subretinal fluid and a retinal detachment. And he originally had an SF6 put in, and then that didn't work, so they had to double down and put C3F8. And then by month 3, we have basically 2200 vision and an opacified hydrophilic acrylic IOL. And so the question was, what do we do for this patient? He has diffuse 360-degree glare, which was most of his issue. And then now we have an IOL and that's opacified. And Liliana Werner has shown that this has happened with hydrophilic IOLs over the years, and then with intracameral injection of air or gas. And then also it can happen with posterior segment procedures, so not just endothelial keratoplasty. So what did I do for this patient? So the first thing I wanted to do was figure out a plan. So I wanted to get this IOL out and whole because I didn't want to cut it up into pieces with an open posterior capsule. Now, I decided to get to it from the inside of the eye rather than from the outside, because when you pull Gore-Tex from the outside, it's already incorporated in the sclera, and I've caused a cyclodialysis trying to pull out the knot. So I do everything internally and just leave the Gore-Tex there. So I do have a pars plana basket suture there to kind of hold the IOL. I took it out and hold through a scleral tunnel. Next, we have our markings. So I'm going to mark 3 millimeters posterior to the limbus because we found that we got less vitreous hemorrhage, and about 4 to 4.5 millimeters apart. I put Gore-Tex off-label in a groove now because I have had some extrude through thin conjunctiva. This is the MX60. Actually, Dave Goldman showed me this technique way back when, and then Brandon Ayers and I have been using this. And basically, you can load the suture in such a way that both sutures are on top of the haptic, kind of pushing it down, and then go through needleless recovery through your sclerotomies. And you can make the sclerotomies with a 1.0 Alcon blade. And then we're going to put this in. Now, we've also refined the technique where we can actually inject this. Now, the key here is that we're about 3 millimeters back. You really don't want to be too anterior, and you really have to load the suture in such a way that you don't have tilt. In addition, you want to do PIs on this patient, so you make sure that you don't have any issues with reverse pupillary block. Now here, the reason why we like Gore-Tex suture in general is that you can titrate it. So you can do a slip knot. You want to tie to one side. And as you're tying to one side, you can do a 2-1-1-1 or a 1-1-1-1. And you have to make sure that the knots and the ends are buried inside. Now, what you'll notice here is that now we have to move towards dealing with his transillumination defects. He couldn't tolerate a contact lens. And so what we're doing here, this is a trephine made by a team from Epsilon. And basically, we're trephinating and then loading up this artificial iris just to go underneath his iris, right, to kind of block these transillumination defects. Now, same thing, I decided to go in a different location of my other sclerotomies, but you can go through the same ones. I went through a different location, and the reason why is because if he developed more UG syndromes or issues, I wanted to be able to take it out easily. You can also inject this through a 3 millimeter incision now, so you don't need this big incision. And so then you go ahead and you want to pressurize the eye. Now, we couldn't stop the anticoagulants on this patient. You can see the blood coming. And so this is a tip that I learned from many, especially Amar Agarwal, which is to pressurize the eye with an air bubble at the end of the case to avoid hypotony and the bleeding. And so this patient actually did quite well. And I think that the take-home points is that you do not place a single piece acrylic IOL passively in the sulcus. I think we have to be thoughtful about the IOLs implanted. So although we love the AO60, you have to get endothelial cell counts, assess their risk of retinal detachment or need for any sort of retina procedure in the future. And we want to avoid, in general, hydrophilic IOLs. In some studies, up to 5% opacification had been seen with air or gas in EK procedures. And we want to be able to utilize the technology that we have to address the glare if we have large iris defects or these transillumination defects that can't be dealt with an imbricating suture. And when you're going in the sulcus, you want to suture it to avoid movement, to avoid a secondary UG syndrome. If you're going to do passive fixation, don't trephinate the AI artificial iris because it can cause issues with an UG syndrome. So I thank you all for letting me share this case with you.
Wow. I mean, just simply, I mean, you did like 4 procedures in one, Nicole. That's just phenomenal. I don't know how you do that. But we still have some questions for you, Nicole. So don't go anywhere. We do have our last speaker for the day, Ahmed, Assaf, and he's going to show us, man, something gaudy. I don't even want to talk about it. So go for it.
Okay, thank you very much for the invitation. This is a case of massive irido-lenticular dialysis. This is a 49-year-old patient. It comes with the massive irido-dialysis of almost 180 degrees. And you can see the lens is hanging in the mid-vitreal cavity because of rupture of almost 350 degrees of the zonules. So surgery started by a placing of infusion cannula in the inferior quadrant through a 23-gauge trocar to pressurize the eye during the surgery. And then started the procedure by doing anterior vitrectomy to clear the vitreous inside the anterior chamber after staining with a triamcinolone acetate. So I prefer, in this case, limbal approach, and you can see that the lens is still hanging by few zonules in the mid-vitreal cavity. And because of the infusion pressure coming from the infusion cannula, you can see that the lens moved anteriorly a little bit closer to the iris, and this facilitated the next step which is posterior assisted levitation of the lens. So I made another sclerotomy, 3.5 millimeter from the limbus, and with the aid of dispersive OVD and cannula and with a scoop, I could levitate the whole lens inside the anterior chamber to be supported by the detached iris tissue inferiorly. And again, we increased the infusion from the infusion cannula, and this way we could explant the whole lens outside the eye through 6 millimeter incision, and this incision was closed temporarily by 10-0 nylon suture. This is followed by periotomy, 180 degrees, opposite to the area of zonular of the irido-dialysis and partial thickness scleral groove, and now preparing for the sewing machine technique to repair this iris dialysis. This is the 10-0 Prolene suture threaded to bent 28 gauge needle. Then the needle is passed through the iris, periphery of the iris, and then to emerge through the partial thickness scleral groove. We externalized a few centimeters of the 10-0 Prolene, and then the needle is retracted again to re-catch the iris tissue, the detached iris tissue, as far as possible, and to pass through the sclera to emerge through the partial thickness scleral groove, few millimeters from the original track, and then again externalize some of the few centimeters of the Prolene suture before tracking. We did the procedure several times, and then cutting the loops of the Prolene sutures and tying the ends together, and this way you can fix the irido-dialysis. And then implantation of the 3-piece lens through the main corneal incision. It was 6 millimeter incision, so I could implant the lens unfolded, preparing for intrascleral haptic fixation with the Yamani technique. We don't have the 30 gauge needle, so we have 28 gauge needle, and this is the sensor AR40. And now the haptics has been externalized, and this is the flange, and the lens was put back into the posterior chamber center on the pupil. I didn't mean at that time to do the pupilloplasty, hoping for the pupil to get down with the subsequent follow-up period. However, the patients continued to complain of intractable halos and glare and photophobia, so I brought the patient back to the OR a few weeks later for the pupilloplasty. I started by doing some anterior vitrectomy because I noted some of the vitreous bands still attached to the pupillary border of the iris together with some fibrinous material. And then I applied the single pass 4-through technique, suture technique for pupilloplasty. I started by placing sutures along the pupillary border of the iris to bring the pupil down. I took around 4 sutures at the pupillary border to bring the pupil down. Then I added another 3 sutures, maybe 3 sutures in the mid-iris tissue to bring the defect, to close the defects in the iris to avoid potential diplopia or halos after the surgery. And as you can see, that the pupil assumed rectangular in shape. However, the patient was pleased by the visual outcomes, and his best corrected visual acuity improved to 0.5 with disappearance of halos and glare after the surgery. And this is followed by closure of the cornea and closure of the conjunctiva. Thank you.
Wow, that was another great case. Thank you so much for sharing. Once again, it was like 3 or 4 cases in one. Well, I thought I wanted to go to Partha Biswas, Dr. Biswas, who is our panelist. And I just wanted to get your opinion, sir. Maybe start us off with a question or discussion related to these 4 cases. We have about 10 minutes or so left in the session. And then after that, I have some questions, maybe Ash does as well. We have some that have been sent in from our audience. Dr. Biswas.
Thank you very much, Ashvin and Sergio, for including me in this beautiful program and in the concluding session, which is the best session, of course.
Yes.
So David, my question to you is, that was a very, very neat surgery that you did. Excellent surgery, your skills and everything all wind together in that surgery. However, why would you not do a femtorexis in that patient and also a femtocylinder carving so that the the cortical matter removal and the soft cataract removal is easier. However, your posterior capsule was did have a rupture and it didn't go end to end, which is saving grace, and you could do off a PCC extremely well. And there was no vitreous coming out, and you placed a Toric IOL. Now, had you had a posterior capsule rupture running end to end, would you have dared to put a Toric IOL is the second part of the question.
Well, I think probably not. It depends where the leaflets are, because you know what axis the lens is. But the only way you could do it would be to not introduce the lens in a way that you don't rotate it, because I think we all understand the rotation, just like the rotation of the nucleus, you're pushing against the capsule, and that's when the tear will extend. So, with astigmatism, I think if it were my eye, I'd say, well, I'd rather not compound the problem. I can treat the astigmatism in other ways. But just for your first question, it's easy. We don't have a femto. I don't do femto, so that wasn't an option. The Zepto is a nice option for complicated capsulotomies because it's a disposable instrument. And I think it is a little bit controversial as far as doing a nuclear softening with a posterior polar because of the potential for gas to go behind. So that's a sort of a longer debate. But I think no matter what, the main thing is just get an intact capsulotomy and have it be not too large so you have options for sulcus fixation in these cases.
David, if that lens would have been harder, would you have modified your technique?
Well, with a dense lens, it's even more essential to chop it in situ. And so we're lucky with these cases that you can sort of chop it in half and then bring each half up. But you are, with horizontal chop, able to sort of bisect it and then sort of move your chopper over and at a different angle and just get, one quadrant out, and then you can sort of angle it. There's always a way to sort of avoid rotation, except in the very, very densest of lenses. So that's a real practical pearl. If you can do chopping, when else do I not rotate the nucleus? If there's a radial tear in the anterior capsule, if there's a zonular dialysis, if there's a lot of zonular laxity, again, you put in capsule retractors. So just think of it as every time I rotate an IOL or a nucleus, I'm pushing against the capsular bag. What do I need to do differently in these complex cases?
Right.
Dr. Soon, we have a very, very interesting questions. I mean, there are a couple of them. I'm going to mix all of them up and give you one question. I think the question is, how long was the follow-up of this patient, number one? What about the IOL tilt in these cases where you have, you're maneuvering around the phimost bag, and it's a trifocal lens, if I'm not mistaken. And also the question around, it's a multifocal lens, I'm sorry. But also the question is around, what about centration in these cases, and how long do the sutures stay? I know there are 4 questions, but you did 4 surgeries in one, so you can tackle 4 questions.
Professor Chee, before you answer that, he has only one question. Why did you not do a glued IOL for them?
No. That is not my question.
You sound like the public prosecutor. Okay, so this patient was done was end of last year. Okay, so this is about 9 months of follow-up, and she's fine. In fact, she's been getting better and better, especially after I yanked her. Okay, because before that she was complaining her vision was still waxy and so on. The lens has not moved at all because each capsule tension segment actually is spanning 4 clock hours. So 120 degrees on either side, actually this lens moves nowhere.
Right.
And as I said, that rip that I had in the capsular bag as I was teasing off the fibrotic tissue, it was leading towards the area of fibrosis. So on its own, it would really not extend beyond, okay, unless I really yanked it apart. So that lens actually, if you saw the UBM at the end, showed that it had no tilt.
It was
And
very
because you're anchoring so broadly, and if you are marking the 2 points for fixation symmetrically, you really don't get tilt. And I've done many of these cases that have got multifocal lenses and they go nowhere and they're really quite good.
I wanted to ask Nicole a question if I could. Nicole, if you were presented with a patient that had not yet had a YAG capsulotomy and was headed for another procedure, either corneal or vitreoretinal, would you do an IOL exchange while you still had the posterior capsule in anticipation of cloudiness of an aqueous lens?
You know, I mean, it's been reported even if the posterior capsule is closed. So even within the bag, we have reports of hydrophilic acrylic opacifying. So, you know, I know that, you know, it's unfortunate and people think it's rare, but the problem is that people come to us for their final procedure. And then if you know you're putting it, if you know you have all these, you can do glued, you can do Yamani, you can do MX60, you can do CZ70, and you do the AO60, you have to be prepared emotionally to tell the patient that this may opacify. That being said, I loved using it. It is sad, you know, that we can't use it or that I don't use it anymore. But I think that, you know, it's a very difficult thing when a patient is looking to you for their last procedure on the eye.
I was just thinking of the situation where there was one that was placed in the bag and they're going to have a YAG capsulotomy in the future, or they're going to have another procedure in the future. And while the bag is still intact, it might be a good time to do the exchange if another procedure is coming. I've had that situation a couple times. I just wondered what other people were thinking.
Yeah, it's always best to not touch the bag before you're doing another procedure and then do it later, for sure.
Nicole, may I ask you a small question? It's at a different angle. This is a patient who had a cup disc ratio of 0.8, 0.9, I believe. And there was a retinal detachment surgery with a gas tamponade, in fact, a twice gas tamponade, C3, F8 and SF6. So the amount of trauma to the disc with all these procedures, and also placing the iris, the artificial iris, is it not possible that the threshold where you were using just one drug with a 0.9 cup disc ratio would tilt or might go overboard, and you might lose the rest of the nerve fibers and you know.
Absolutely. And I think that's a great point. And what we didn't talk about is the patient ended up having a huge vitreous hemorrhage, having issues after, needed a tube. And so that's the follow-up, but he is 20/30 with that 0.9 cup to disc. So this post-operative management, I mean, we could not, because, you know, he's had horrible AFib and strokes, we couldn't stop the anticoagulants. So you bring up the best point. He was a very good patient, consented, understood the risk, and I think that's critical. But the 0.9 cup to disc was based on years of having high uncontrolled pressure, and why he was only on one medicine and, you know, adequately controlled. I mean, it was 15, we probably wanted it 12, 10, I don't know, but it did push him over the edge. But fortunately, we watch him like a hawk, and he has his tube and it's still working.
Great.
Dr. Ahmed, there's a interesting question. Is there a systematic manner that you deal with these cases where you have iris trouble, lens-related trouble? Do you deal with it in a systematic manner, or is there any system for it? I mean, I think the audience wants to know.
No, there is no exact system for each case. Is individualized. In this case in particular, I want to save the lens before losing the lens in the posterior segment. So I tried as my priority to just deliver the lens outside the eye and then deal with the iris dialysis, followed by visual rehabilitation by the IOL implantation, whatever the technique is, glued IOL or Yamani or whatever, maybe more, iris claw lens, for example, if possible. So each case has its own path.
Any tips on the sewing machine technique? Because that seems to be very interesting.
Yes, it was very interesting. Agreed. My technique is just to use the 28 gauge needle as small as possible. smaller than this or narrower than this won't pass the 10-0 Prolene suture. So this is the smallest gauge possible for this technique, because you don't want to injure the iris tissue as much as you can, because sometimes the iris tissue or the needle may cut through the iris tissue and cause radial extension. So this is my first tip. And the second tip is to externalize enough thread of the Prolene outside the eye, so you have enough lens to tie the free ends of the Prolene sutures on the sclera after cutting the loops.
Okay.
Ashvin, may I just carry on to the very nice points that Dr. Ahmed made. Sewing machine technique is a wonderful technique, but it has to be done very meticulously, and there are certain little practical difficulties which can come in the way. The 26 gauge needle and the needling of the 26 gauge needle with that redundant iris might be a little difficult, and a counter pressure needs to be made so that the dialysis does not extend and you're not pushing or pulling out the dialysis at its end. So the pressure counter pressure afforded by a 26 gauge needle as well as the 9-0 is something that is very, very important, number one. The other thing that is quite important, and I had a case in which the iris tissue, while I was needling it, got entrapped between the needle and the 26 gauge, the groove of the 26 gauge. And then that pulled out the iris. So these are very small things that possibly can happen, and has to be done very, very meticulously. But it was an excellent surgery done, sir, and I'm sure it must have taken you hours to do it. But the other caution is the retinal evaluation after such a traumatized eye, a vitrectomized eye. So constant retinal evaluation is something that definitely is warranted, maybe for the patient's lifetime.
Yeah, absolutely. I agree with you. Yeah.
David?
Hey, Tom, can I make a point?
Yeah.
Sunpek and Nicole's cases, I think we all realize those are things that maybe 1 in 1,000 surgeons or less can do those kind of cases. So I think the one point the audience should get is in both of those cases, those problems were all preventable. In Nicole's case, obviously the lens is in the sulcus, so okay, that happens. But for it to go that long, someone had to just be hoping that this patient wouldn't get into trouble, and somehow this would be okay in the end. And if that patient had simply been referred much earlier, that wouldn't have gotten into that spot. And with Sunpek's case, if you're going to do a multifocal and you're concerned at all about zonulopathy, you have to put in a CTR or rethink it. And even more so if you're doing some type of a plate haptic lens. And that type of capsule contraction results from a combination of diffuse zonulopathy and a small capsulorhexis. So you either have to enlarge the CCC secondarily at the end, but by all means put in a CTR so you don't get into that point. Because I think just watching those exhausting cases makes the point. It's a lot harder to fix it if you can prevent it in the first place.
May I ask a question to David?
Yes, please, go ahead.
Yeah. David, I like your surgery very much, but why not to guarantee against rotation of the IOL? Because you couldn't remove the viscoelastic underneath the lens, because of course you're inviting more troubles and inviting more vitreous in this case. So I had a similar case, and I preferred at that time to do the reverse optic capture, to just prolapse the optic above the rhexis, so I can guarantee this way better stabilization of the lens against rotation. So would you comment on this?
I think that's a great point. I think we're lucky with the Acrosoft. My partner and I, we reported more than 4,000 now we're writing it up, and the rotation rate post-op, need to go back, is 1.2%. So I think in this case, remember that there's a hole in the posterior capsule, so the OVD goes backward through the hole and you still get the contact. But if it did rotate, you could go back and I think still rotate because of the PCCC. But that is a great technique that you mentioned when you have recurrent rotation, and that's to pop the optic. the haptics stay under the bag. And unlike Nicole's case, because that lens can't move and it's sort of kept posterior by the optic capture, you won't get an UGG syndrome.
I just wanted to address, these what David was getting at. These are very complex cases, and if you're not used to doing them, you might want to just move slowly in the direction of doing them. And I wanted if Nicole could comment on that, or others, about how to move forward slowly to acquire these skills.
Yeah, we talked a lot in the past about, simulation models and being prepared and having your toolbox ready, knowing exactly what equipment you need in the room, depending on how the case is going to unfold. Pick one technique and try to master that. But you must know basics about anterior vitrectomy, pars plana approach to anterior vitrectomy, prior to doing any of this. So if you want to start with an aphakic eye that's already vitrectomized, that's like the best case to start with. And we talked about how to, the surveillance of retina doctors, and retina help over time that you must have, and sometimes over a lifetime, as was discussed. Simulation models, the simuli is what I use. It really helps you mimic the maneuvers in the eye. So you can get the lens from the company as a research lens. You can take some Gore-Tex and practice with that. Or if you don't have that available, you can take a lens and practice the intrascleral haptic fixation techniques. I started using Gore-Tex and then transitioned into intrascleral haptic fixation. But I do them all, and it depends on the conjunctiva that's available and all these other factors of which one I choose. But there's nothing superhuman about my hands. It's just that I go slow, I review my videos, I'm meticulous, and I make sure that the vitreous is taken care of.
I beg to differ. There is something supernatural about it.
You just have to practice, and you have to really be critical of every step of what you're doing.
Any other comments from anybody else about moving forward to learn how to do this sort of stuff that we're seeing this morning? I guess is almost afternoon here.
I think that you need to be you must be able to handle whatever complications come your way. So it's like a plan A and a plan B. I can't detect the capsular fibrosis, or if I rip in the capsule, what can I do next? I was hoping to be able to put in the CTR that should have been there at the start. All right, but once I had a rip in the capsule, that I knew, okay, if I can't do a CTR, then I can still use tension segments. I just need 2 of this. So I think that, if you have handled cases that are less difficult and you can master bits of it, you can always put it together when you deal with a very difficult case.
If I may add to Tom's question, and I think if all the speakers can also comment on that, is tissue handling is something that is very important in these cases. And what do you guys do differently for tissue handling? Whatever tissue, it could be a capsule, could be an iris, could be a cornea, whatever it is, but go ahead, shoot.
Well, if I could come in and, Ashvin, you've said a very, very important point, and this is something I think our residents learn over time, or we learned it over time as well. The stricter your mentor has been in the formative years, the better your tissue handling will be, the more graduated will be the learning. If you have had a mentor who has said, just go your way, you can learn it. There can be no fast track in a meticulous surgery, and especially when it is complicated surgery, when multiple tissue handling, multiple decision making, not only pre-operatively, but per-operatively, and even post-operatively, everything goes on. And thereby, if it is a word to our residents, I think the first thing should be good tissue handling, supervision by the mentor or the supervisor, good suturing techniques, which our residents have now forgotten. And so these are things, as well as, especially if it is a traumatized eye, and Dr. Ahmed's case, a very good diagnosis and evaluation of not only the scleral, the eyeball, but also beyond, and whether there's a a rupture of the globe or whether there is a contusion of the bones. So everything will go on to make up the whole importance of the surgical process and the outcomes as such.
Well, the other thing is the instruments for tissue handling. It's, you know, we've all tried to do things with the wrong instruments because we didn't have them or we didn't want to invest in them. And fortunately, so many companies now have these microsurgical instruments with interchangeable tips. I think that's really enabled us to do things that were just too hard before. And I love all the points earlier about learning new techniques, just the really obvious ones. It's really hard if you're rushed. So put these cases at the end of the day, leave lots of time for that. If you're on the fence, do a retrobulbar, peribulbar. And, you know, I usually tell the patient also that, you know, this case is going to take longer, but also the recovery is going to take a lot longer. You know, don't think about it like a cataract operation. And I'll say it may take 3 months before you see well. So you set expectations that are going to be easy to meet.
I would like to add one more point that keeping the eye pressurized all the time is very important. So we have to fix infusion cannula, whatever, in the pars plana or the trocar or the anterior chamber, because sometimes these eyes are getting soft during the long, lengthy procedure. So it's most important here to keep the eyeball pressurized during the maneuver, and you can switch off, switch on the infusion, whatever, according to the steps of the surgery.
Nicole, soon.
Yeah, I mean, I think that's a great point. You know, going back to the preoperative examination, if you look at a patient and you know that you can't mobilize their conjunctiva, then, you know, scleral fixation with sutures is not going to happen, and you want to go towards, you know, a glued technique or a Yamani technique. So that's the first step. Observing the patient laying down and sitting up will help you understand if you can approach the lens that's dislocated or something that's happening, or whether you need retina backup or you're just a better surgeon that's international and trained with everything. And then understanding how to control the pupil. So you don't want to give preoperative dilating drops if you're going to suture to the iris, right? So you do your retrobulbar, you do all your manipulations, you use hooks, and then you want to use your intracamerals to control the iris. And so you want to bring these pupils down at the end of the case to make sure you can see stability and make sure there's no vitreous prolapse. So those are some of the pearls, I think, you know, in looking at these patients. And I tell all patients it's going to be 6 weeks before I know, you know, what your refractive outcome is going to be.
I just want to make one little comment. It's related to what Nicole said, and that is that, you know, during this downtime from COVID, we really took advantage of that in our operating rooms, which were otherwise dead, to use the simulated eyes in the operating room. And that's one of the really cool things about it. One of the sort of paradigm busting things about the simulated eyes is that you can use them in your OR because there's no cadaver material, there's no animal material. And so then you get a very high fidelity experience because you're using your instruments, your microscope, your foot pedals, and in some cases even your techs can help with that simulation. And so that was a great experience and one of the real eye openers of the COVID time for us, in addition to Zoom, which is the other one. And so I just highly recommend that. There's 4 or 5 companies that make these devices, and it's been a game changer for me. And I think, for example, if you're comfortable on simulated eyes doing the Yamani technique, it opens up a whole realm of other things. Once you're comfortable with that, you're less worried about other stuff happening. And so anyway, I just highly recommend getting in your own OR with these simulated eyes and practicing stuff, and you'll find it really fun.
Dr. Soon, we're going to close after your comments, so we're waiting for you, the final talk.
So I want to encourage surgeons to use both hands when they operate. Okay, so sometimes you're just trying to get the lens in, and I've seen you, Ashvin, you just use a micrograsper, hold the haptic and stabilize the optic as you get it into the right space. Okay, and it's like you're doing bimanual capsulorectors that I like to talk about for the very, very severe zonulized eyes. When you don't have a counterforce being provided, use your other hand to grasp the capsule. The capsule will not give way. And so like this case also, when you look at how I dissect the fibrotic tissue away from the capsule, you can't imagine that you can actually tear the fibrotic tissue and not rip the capsule. But you need to provide that counterforce. So you need to use both hands to actually control exactly what you're doing. Just using one hand and expecting the zonules to provide the counterforce will actually ruin the rest of the zonules. So I just want to encourage you all to be brave. Use both hands with appropriate instruments.
Ash, could I add just one more comment?
Yes, absolutely.
Yeah, no, I mean, I think along with Tom's comments about the pandemic, I think it's going to be interesting to see if Zoom or these video or virtual conferences actually help with skills transfers. You know, even at a live meeting, you watch the video and it goes by and you can't see it again. Whereas here you can replay it and so forth. And, you know, I know it's been said, but ASCRS, we did the very first virtual meeting because it just happened 2 weeks ago. And I think a lot of people feel they got more out of it because they could replay parts, look at the figures in the papers, look at the film again. Things that you can maybe, it's like watching a sporting event at home when they have replay, when it's live, you only see it once. And so this is the first, many people have never been able to attend an ASCRS meeting if they're international. This is the very first time it's virtual. Thank you for putting the link on your website, the WWCRS website, and ASCRS has decided for the very first time to make an international access for a lower fee, and hopefully people will get to see their first ASCRS meeting. It includes the film festival, which, by the way, is where Sergio and Dr. Yamani and all of the Agarwal, Dr. Chee, everyone has had award-winning videos, you know, on this. Nicole is a judge frequently, and you can see all these videos for the first time live.
Thank you so much, David. Those were excellent comments, and I think ASCRS support has been absolutely stunning and a wonderful support to us. So thank you, David, and thank you all of you guys for being a part of this WWCRS 2020. We couldn't have done it without you guys. And I'm going to reach out to everybody else very soon. But closing comments, I'm going to just say we're coming to close this, and thank you so much, Tom, and all the speakers. Partha, thank you so much for being here.
Ash, can I say?
Absolutely.
Guys, thank you for this session. I love this session. I'm fan all of you. When I begin in the meetings, I'm fan of you. Nicole, I don't know if you remember, but my first presentation in ASCRS was 2015, and I was so nervous. You give me relax in San Diego. David, thank you. Ahmed, Partha, and Tom. Thank you to be in this meeting. And I have one challenge for Ash, because I am the marketing guy. And Ash is the program scientific guy. The next season, I want more than 100 speakers. I don't know how to do it, but the challenge for you, more than 100 speakers in the flyers. Okay, my friend? See you.
He's given me a task and on hand. Anyways, so coming to close this 2-day mega ophthalmology webinar, I'd like to say just one very, very important thing. Sergio and I are solely here today going out of our way because we want to give back to the ophthalmic community what it has given us actually. The panelists and speakers, moderators, they've backed us so much that each and every one of us in the back end, it makes us warm inside. We missed a couple of people, but we have to thank our moderators who went out of their way once again to fill all the voids, and they're just simply the true heroes and true rock stars of this event. Let me just name them: George Waring-Ford, Arthur Cummings, Ronald Kruger, Ashraf, Boris, Bruno, Renato, Susan Jacob, Priya Narang, Amar, Elizabeth Yu, John Berdal, William Trattler, Marconi Santiago, and Tom Oetting. Thank you so much, guys. You guys have been just phenomenal. We've probably seen close to about 20,000 people around the world who saw this event in the past 2 days. We don't know the exact numbers yet, but we'll get back with that. We will have a WWCRS Season 2. We wanted to announce that here. We will have that. And as I have a challenge on hand, what Sergio says, I have to match that 100 speaker challenge. But yes, so stay tuned in the comfort of your homes. Keep a watch out for that website, guys. This show will be telecasted on the Facebook and YouTube channels as is. And we are happy to take all the social media questions on our social media handles. Sergio and I will take all the questions and get back to you ASAP. The backend team, what can I say? Sergio's team, Giovanna, Igor, they just made all the moderators, panelists, and speakers look like absolute rock stars through their tireless efforts on marketing. My backend team with Ravi, Kumar, and Sanu, well, they've just been a well-orchestrated machine, conducting a relay of the whole webinar. We've learned a lot from organizing this event itself, let alone learning from the speakers. We will ensure that all your feedback is taken into consideration moving ahead. So please keep your feedbacks coming. We are waiting for them. We wish you a safe recovery back to your practices and hope the patient volumes come back as is 2019. A special thank you to ASCRS constant support, Medaula, LASAR, Dr. Agarwal's Clinical Education and Ophthalmo University. But the man of the moment, my most special and most important thank you to my dear friend, Sergio Canabrava, whose magnetic, charming personality have people talking about him all the time. I love you, dear friend. Please share a few words and we will close this webinar right now. All right. Thank you, guys. Bye-bye.
Thank you, my friend.